Well, good afternoon and welcome to our PeaceHealth webinar on WATCHMAN Reducing Stroke Risk for People with Atrial Fibrillation. The information presented today is general in nature and does not replace the advice of your personal healthcare provider. In fact, we encourage you to talk with your provider about specific questions related to your health conditions. So my name is Chris Caldwell, and I have the honor of serving PeaceHealth Marketing Communications team based here in the Portland, Vancouver area. I'm pleased to be with you today as the moderator for the presentation. Before I introduce our guest speaker, I would like to remind you that PeaceHealth is ready to help when you need us. Many of our doctors offer video visit appointments. If you haven't done so already, set up your My PeaceHealth account online so that you can conveniently make appointments, track vaccinations, receive test results, and manage prescriptions. All handy stuff. If you already have an account, log in to make sure your contact information is up to date. In today's webinar, we invite you to engage with us, and here is a few ways how. You can ask questions in the little chat window here and go to webinar, and we'll do our best to address as many of those questions as possible during the Q&A portion toward the end of our presentation. Also, please be sure to complete our brief survey at the end of the presentation, which helps us to make ongoing improvements to our webinar series. So with the housekeeping out of the way, it is my great pleasure to introduce you to our speaker. Dr. James Reiss is a board-certified cardiologist and cardiac electrophysiologist, which is a mouthful, but basically means he has specialized expertise in treating problems with the heart's electrical activity and rhythm. Yes, hearts do have rhythm. He joined PeaceHealth Southwest Washington Medical Center, Vancouver in 2005 after completing fellowships in cardiology and electrophysiology at Oregon Health and Science University, or as some of you may know, OHSU. Prior, he attended University of Washington Medical School, where he received his medical degree and completed a residency in internal medicine. Highly regarded among peers and patients alike, Dr. Reiss served as past chair of the cardiology section at PeaceHealth Southwest Washington. His patient reviews are outstanding, 4.91 out of 5 stars for more than 100 reviewers. Says one recent reviewer, highly intelligent and highly caring. He spoke with authority as a good friend would. I can attest to these qualities, having worked some with Dr. Reiss on this presentation, and would add that I particularly appreciate his terrific wit as well. Outside of work, Dr. Reiss enjoys travel, classical music, and the arts. He is fluent in Russian and volunteers yearly in St. Petersburg. Thank you for being with us today, Dr. Reiss, and I'll go ahead and turn the mic over to you.
Thank you, Chris, for that very kind introduction. I'll just make sure, Chris, can you hear me okay?
I can.
Okay,
yeah.
Good. I just want to make sure, so I'm assuming everybody can hear me. Well, it's my pleasure to be here. I very much appreciate this opportunity, and I appreciate you all having an interest in what we're talking about today. The question on the table really is atrial fibrillation, but we specifically want to talk about some treatment options and very specifically talk about WATCHMAN as an alternative to, pardon me, as an alternative to blood thinners. Let me go back half a step and just maybe set the stage by talking about what atrial fibrillation is. Atrial fibrillation is an arrhythmia, an abnormal heart rhythm. It's actually the most common heart rhythm disturbance that we deal with every day in our clinic, and it's very, very common. I'm sure each of you knows people who has atrial fibrillation. It's a unique form of an arrhythmia, and then it's irregularly irregular. It's very unpredictable. People describe it as popcorn popping or static on the car radio, if you remember when you used to be able to turn the dial between radio stations. just to give you a good sense as to how this happens, I wanted to show you two pictures here. There are two pictures of the heart. The one on the left in the screen in front of us there shows you the normal conduction system of the heart. Now, your heart has 4 chambers. Think of it like a four rooms in a house. The lower 2 chambers are the pumping chambers. They're called the ventricles, and they really only do what they're told to do, and they get all of their signals from above. The upper 2 chambers are where the electrical signals in the heart begin. But it's important to understand that as a rule, the right upper chamber, now that's the one on the left side of our picture, but it would be on the patient's right side, is the normal conducting chamber in the heart. And at the top of it, there's a tiny little point called the SA node, or the sinoatrial node. And that node actually works like a lighthouse. It beeps once a second to keep the heart beating on a regular basis. Now, the next picture will show you what happens in atrial fibrillation. And the left upper chamber normally is very quiet. It's like a shed in the backyard of your house. It doesn't have any purpose. If it got blown away in a storm, nobody would really care. But as we get older, that left atrium, or the left upper chamber, becomes the source of all kinds of trouble, specifically abnormal rhythms. And so think of it like you're in a house listening to a quiet symphony, and all of a sudden the kids in the upstairs bedroom turn on a garage band. That's what it sounds like to your heart. It's a abnormal, irregular rhythm. And that's what atrial fibrillation is. It's also important to understand that there are only 2 things, and we'll talk about this in a minute, but there are only 2 things that cause atrial fibrillation. And I get this question a lot. Well, what did I do wrong, or what kind of things could I have done to prevent this? The 2 things that cause atrial fibrillation are, number 1, age. And so it's important to understand that atrial fibrillation is unheard of in children. It doesn't exist, but it's an age-related problem, and in people in their 70s and 80s, it's an epidemic. The other cause of the 2 is triggers, and those triggers originate in the left upper chamber, the left atrium of the heart. Some of these episodes can go on for minutes to months, as we've talked about, but it's also important to understand that the prevalence is probably much higher than what we realize. So it's been estimated that it affects somewhere between 2.5 to 6.5 million people. I think that's a gross underestimate. We all know people who have atrial fibrillation, and it's sometimes underappreciated because people don't feel it. Some people feel it terribly, they hate it. Other people have no idea they're in it. It's picked up by chance. It affects adults in all age groups, and it's not limited to people who have pre-existing heart conditions. You can be perfectly healthy otherwise and still have atrial fibrillation. We've seen it in people in their 20s and 30s. It's rare, but we see it. And we see it in perfectly healthy people in their 70s and 80s. As I mentioned, of the 2 risk factors, what we need to keep in mind is age is the primary one. If you're old enough, you're likely to get it in some point in your life and in some form. Other factors can tend to play a role, but they really more play a role in perhaps accelerating the atrial fibrillation. So sleep apnea that's untreated, for instance, there may be some component of family history, but quite frankly, if you ask people, everybody's family has somebody with atrial fibrillation. And other factors such as heavy bicycle riding, for instance, for some reason seems to contribute to atrial fibrillation. Professional bicycle riders have a problem with it. Heavy alcohol use, things like that, but primarily it's that age issue. So whenever we think about atrial fibrillation, it's important that we remember 3 things, or think about 3 things. The first is that we always manage it by trying to control the rate. So people will feel the rate sometimes before they'll actually feel the rhythm. They'll just feel their heart racing. So that's where medication comes in. In terms of rhythm control, the world has really changed. When I moved to Vancouver to do my work 17 years ago, and I know I don't look that old in spite of my hair, but I've been here a long time, we really had very few options for controlling atrial fibrillation. Today, ablation is an excellent option for controlling the rhythm. But the third most important issue, or the third issue, and I would really say the most important, is stroke prevention. So rate control, rhythm control, and stroke prevention. And that's what we're going to focus on today. Strokes are debilitating. They just ruin people's lives. And as we age, our risk of stroke increases, and it increases even more when you have atrial fibrillation, and it increases even more when you have atrial fibrillation and certain risk factors, as we'll talk about. So the connection between atrial fibrillation and stroke is well understood, going all the way back to the 1980s when a number of clinical trials were run to investigate this, and some of them were run in this area. We were able to identify that strokes caused by blood clots forming within the heart are definitely related to atrial fibrillation. Now, not everybody who has atrial fibrillation will have a stroke, and not everybody who has a stroke will have atrial fibrillation, but it's important to understand that as we get older, our risk of stroke goes up. When we get older and have atrial fibrillation, of course, it goes up more. And then there are a number of factors that can actually increase the risk of stroke pretty dramatically. And they're listed over here on the right side. So if you look at the risk factors in that right-hand column, you can see from heart failure and high blood pressure to advanced age, all of those play a role in raising our risk of stroke. So to calculate your risk of stroke, we use something called the CHADS-VAS score, and that's in the top left-hand column of the lower section there on the diagram. You'll see that we can start to add in risk factors, and you can type this into your Google on your computer, and it'll tell you how to calculate your own score. But the risk can go from no higher risk per year than the average, which is this CHADS-VAS score of 0, up to 9, where it can be up to 15% per year risk of stroke. So that's pretty high. That's a chance that in every 6 years you might have a stroke. So we use that then to determine patients who would benefit from blood thinners. And there's no question that blood thinners work. Absolutely no question. They reduce the risk of stroke by 2/3. The problem is they actually raise the risk of complication, specifically bleeding. So WATCHMAN, which we'll talk about in a few minutes, was an excellent step forward to allow us to still reduce the risk of stroke and yet stop anticoagulation, stop blood thinners. So you have 3 options for reducing, I said managing, but it really means reducing the risk of stroke for people with atrial fibrillation. You can treat them with blood thinners. Warfarin's the old standby. It's been around forever. But it has its set of problems, including people have to be very careful what they eat. Then the level that it's protecting a patient can vary dramatically, even from day to day. And it's difficult to take because it interacts with other medications frequently. So a new alternative came out a number of years ago. Actually, there are a number of them, but a type of drug called what we call a NOAC, which is kind of a funny expression, but it's a novel oral anticoagulant. What's good about these is you just take them and forget about them. You don't have to have blood tests. They rarely interact with other medications, and certainly don't interact with most foods, which is a problem with warfarin. And they're very effective. And I believe they're more effective than warfarin, in part because it's a controlled medication. So you can take a blood thinner, and that's fine. Again, you reduce your risk of stroke by 2/3, terrific, no argument there whatsoever. You could also do nothing, which is not a great idea, but some people are forced to do that for a variety of reasons. They're either not able to take medication, and around the world, that's one of the problems with these medications is people simply can't get them, or there are complications when they do take them, such as bleeding or drug-drug interaction with other medications. So the third option, and that's what we're going to focus on for the next few minutes, is closing or removing the appendage, which is a little pouch that hangs over the heart, which is where we think most blood clots form. So what WATCHMAN was designed to do was to go from inside the heart and close that little pouch. Now, that pouch can be removed. Surgeons can remove it, and they will. Our colleagues in surgery will do that for us sometimes when they're going to take a patient to, say, bypass surgery. But not everybody needs that surgery, so we're really stuck since they can't just go in and take it off on anybody. So we have WATCHMAN as an alternative where we go inside the heart, and I'll show you in just a minute how we do this, and implant the device. Let's look at the next picture. So the left atrial appendage, think of it like an earlobe. It hangs over the outside of the heart. And that little pouch beats every time your heart beats and empties. It's fine, it works great, until you go into atrial fibrillation where the pouch just wiggles. It never actually fully empties. And that's where we get into trouble. So this is what that pouch looks like on ultrasound. And you can see the yellow outline there shows you the little pouch hanging over the side of the heart. But what you'll notice on the inside is a blood clot. And that's the trouble. Those blood clots, which is outlined in red, those blood clots that form in there tend to want to break loose. So the interesting thing about blood thinners is you're taking a blood thinner to thin your blood from head to toe, when you don't really need it anywhere except in this tiny little pouch. And so that's where we get into trouble with blood thinners. So ideally, if the blood thinner is working, it will discourage, but not prevent all, but will discourage blood clots from forming in that pouch, which can then break away. And part of what causes the trouble is not only is it slow blood flow going in and out of this little pouch, but the pouch itself is not smooth. It doesn't actually look so much like what we see here, but in 3 dimension, it's got all kinds of curves and little divisions within it that like to hide blood clots. So what WATCHMAN does, and you can see in this picture, is it's a little device that looks much like a parachute, or I say a jellyfish. And we place it inside the pouch from the inside of the heart, and then remove everything else. Once we get it there, we remove all our other tools and just leave the WATCHMAN. And so on the left side of the WATCHMAN device, as we're looking at the picture, is the inside of the left atrium, the left upper chamber of the heart, and blood will just flow around it and not form blood clots in most cases. What's to the right of the WATCHMAN is an empty space that's the appendage, and it can form blood clots, but we don't really care. It's kind of like Las Vegas. What happens in Vegas stays in Vegas. Well, what happens in the appendage, blood clots, doesn't get out, and that's fine. It can stay back there. Think of it like placing a cork in a bottle and then turning the bottle upside down. Once that cork is in there and it's in a stable position, nothing's going to come out of that bottle, and that's what happens here. And that's why this is so protective against blood clots that lead to stroke. And we wanted to show you a short video to show you how we actually implant the device. And I'll let that play, and then I'll talk to you a little bit more after that. It's only a few minutes long here. Okay, so we can probably advance to the next slide. So you got to see that. It's actually only 56 seconds. That wasn't so many minutes long. But what you'll notice is that the device looked a little different from what I showed you earlier. And so truth in advertising, that's the new generation of WATCHMAN, and that's the one we implant here. It doesn't so much look like a jellyfish, but it looks like kind of a hockey puck, and it's a much better design. It's safer, easier for us to implant. And I think more effective in the way it was designed to stay in place and effectively seal that little pouch. So when we put these devices in, we measure from inside the heart using ultrasound. And I just wanted to show you these 4 pictures in the lower right-hand corner. These aren't the same picture. They're actually the same part of the heart, but we're looking at them in different angles. So we spin, like you spin a dial around on a clock, we're spinning the probe inside the body around to be able to measure that little appendage from all 4 different directions. And once we have a good sense for the size of the opening and the depth, then we plan how we're going to implant the device. This is all done during the procedure itself. Now, this is not open heart surgery. You need to understand this is a very straightforward outpatient procedure. People go home afterwards. We go in through the right femoral vein. So that's the vein in the right leg. I didn't say artery. Don't leave here hearing artery. Everybody does. It's a vein. It's a very safe approach. And when we go inside the heart, we cross from the right to the left upper chambers using a tiny little wire to cross over into the other side, and then we deliver the device. And to make sure that we're able to get the device in appropriately, you'll see 2 pictures here for what we do. The picture on the left was taken during the implant of a device, and there's a little shepherd's crook that's there on the middle of the screen. That's a soft little tube that we put into the appendage to plan where we're going to leave the WATCHMAN device. We actually inject dye or contrast, we call it, into the heart, and then light it up and then pick our approach based on what we see there. What you'll see in the next picture on the right side there is that we're actually implanting the device. So it's a little hard to see, and I don't know if we can circle that with a red marker, but you'll see that the WATCHMAN right there, that WATCHMAN looks like a little couple of pieces of wire coming out of the end of that tube there, and the WATCHMAN is being deployed right here. I'm circling around right here. So it's being deployed into the heart, but what you'll notice is just above it, there's a dark patch. And that dark patch is contrast that was earlier injected into the heart, but it hasn't ever emptied, which tells you what happens when blood clots form up there. They get caught and they don't like to let go until the moment when you don't want them to let go. So on the picture on the left, we've now expanded the WATCHMAN, and I've circled it in red. You can see the little struts that come out. And so we're actually tugging on it at this point. You can see we're kind of pulling from the wire and pulling it to make sure it's stuck, which is what we want. We like things that are stuck. And then if you look at the right-hand picture, you'll see that same image in ultrasound. And so that red arrow shows you where the device is, and below the device is the left atrial appendage, and behind the appendage is an empty space where blood clots would have formed, but now can't get in or out of there. Blood can get in, but no blood clots can get out. So this is really based not just on our experience, but on a number of clinical trials. And the device has been in development for 15, 16 years now. But the first clinical trials came out in 2013 and in 14. We started implanting the device in 2015. We didn't really take off until 2016 because the FDA did approve the device, but Medicare wasn't convinced, so they wouldn't allow us to put it in Medicare patients at first. In 2016, they started to approve that, and it took off from there. And we've been doing many, many of these devices. It's a very common procedure for us. The biggest advance has been in the last couple of years when we were part of the Pinnacle Flex trial. That's the bottom trial you'll see there. We were actually part of that. We were one of the implanting sites, and that allowed us access to the newer generation of device where it's closed on the end. So instead of looking like a jellyfish, again, it looks like a hockey puck. And that has really improved, again, the delivery, makes it easier, and the safety, and it makes it much easier to move the device if we don't like the position. So the benefits of WATCHMAN are pretty dramatic. People will consistently say, you know, this has really changed my life. They're no longer taking blood thinners. Their risk of stroke is reduced at least as much, if that makes sense, as taking blood thinners, and even more, in my opinion, because with blood thinners, you have an increased risk of bleeding causing a stroke. Well, that's gone because you're not taking blood thinners. And it really does change people's lives. It is a safe alternative to blood thinners, which can be very expensive. It's a quick procedure. It takes under 2 hours. It's very safe. People come in the morning. They go home later that day. Very rarely does anyone stay overnight. And that would only be if it were very late in the evening and we felt more comfortable with them staying with us. It reduces the need for medication immediately. We immediately start to dial back anticoagulants or blood thinners. And it's equivalent, as I mentioned, in the reduction for the risk of thromboembolic stroke. Now, that's a stroke caused by a blood clot in the heart, but it's even a greater risk reduction for bleeding strokes. And there really is no age limit on these devices, on these WATCHMAN. We put them in people in their late 50s and people in their early 90s, and they work very, very well. So I guess in conclusion, we've covered a lot of territory, and I appreciate everybody being here and your patience, but it's important to understand that atrial fibrillation is an age-related problem. It's a complex problem, but it's manageable. And the 3 areas that we approach when we manage it are controlling the heart rate, controlling the heart rhythm, neither of which we've really covered much today. But the third and most important is to reduce the risk of stroke. Atrial fibrillation won't hurt you except in that risk of stroke. I think of it like driving your car, a nice 8-cylinder Buick, to the grocery store, but you've only got 5 cylinders. You're not going to win any drag races, but it will get you to the store, but it's not a very sexy ride. So atrial fibrillation is an inefficient rhythm. People don't like it, and it's not conducive to an active lifestyle, but it doesn't hurt you as a rhythm problem. What it does is raise your risk of stroke. So having said all of that, the greatest risk of AFib is the risk of stroke. We can reduce that by 2/3 with blood thinners. If you're taking them and you're comfortable with it, keep going because they're doing you a favor. But WATCHMAN is the alternative to blood thinners, which is for people who can't or shouldn't be taking blood thinners. And for those people, elderly people, people who are falling, people who have gastrointestinal bleeding, we have a variety of reasons why people really should not be on these medications. Then WATCHMAN is a fantastic alternative. It's a safe, quick, and effective life-changing procedure. So thank you very much for your time, and I'd be more than glad to entertain any questions or thoughts or concerns people have.
Well, that was excellent, Dr. Reiss. Thank you so much for expanding our knowledge about this innovative heart rhythm treatment offered at PeaceHealth today. I'll give our listeners just a little bit of time to have their questions into the little chat window here and go to webinar. And while you're doing that, I want to remind you that a recording of this webinar, as well as the slides that you're seeing here on the screen, will be available on our site shown here on the screen, which is peacehealth.org/WATCHMAN-webinar. You are welcome to rewatch the recording anytime or share it with a friend or family member who might benefit. So I see some questions flowing into the window. Let's see. So the very first question submitted, let's address that. Can you get a WATCHMAN device implanted if you have a pacemaker?
Can I go ahead and answer that?
Yeah.
Can I answer that? The answer is yes. They're really two different devices. Pacemakers are implanted with wires, for those of you who don't know, that go into the heart through a vein, but from the shoulder. Chris, can people see me?
Yes, people should be able to see you.
Well, I'm sorry you're stuck with that. But if you can see where I'm pointing, a pacemaker goes under the collarbone on the left side here, the wires going into the heart. So they go into the right side of the heart, and there's usually 2 wires, not always, there's usually 2. One in the right upper chamber, one in the right lower. So remember when we put this little WATCHMAN device in, it goes into the left upper chamber. So we'll pass through the right, passing from the kitchen into the living room, but we'll deliver it out into that appendage over the left atrium. So while we'll go by your pacemaker wires, we won't disturb them, I promise, we'll leave them alone, but it has no effect whatsoever on a pacemaker or pacemaker wires. Many of our patients come to us with pacemakers in place and they receive a WATCHMAN regularly.
Great. Really appreciate the analogies to kind of paint that picture. Our next question is, would this be a procedure for someone non-compliant with medication?
Are you talking about me? Because I'm the perfect patient for it. I can't take Medicaid. I can't remember to take them. Yes. Now, it's become much easier now that we have the WATCHMAN Flex, because it's a little more forgiving for us in terms of medications that we use after the implant. But the way it works is this. We will have someone hold their blood thinners for a couple of days prior to the procedure. And that's just because of the rare chance we might have bleeding associated with the WATCHMAN. Then we would not want them to be on that blood thinner so we can control things. But once the device is in, we ask them to stay on a blood thinner, but it can be a milder form of a blood thinner, something like Plavix, which is a brand name for a medication called clopidogrel. That plus aspirin for about 3 months. Then what we do is we stop those medications and only go to aspirin for the rest of your life. But at 4 months after the device is implanted, even if you're non-compliant in that period before the WATCHMAN, as long as you can take a blood thinner for 3 months in some form for 3 months after the procedure, then at 3 months we stop all that, leave you on aspirin only, and at 4 months we'll take another look with ultrasound. And if there's no blood clot on the device, and if the device is in good position, then it's aspirin the rest of your life. It's very simple. Most people can do that for 3 months, even if they're non-compliant.
Great. And we're going to try to squeeze in just another couple quick questions and answers, Dr. Reiss.
Yes, delighted.
Our time is running out. So how do I know whether I shouldn't be on blood thinners? So just lots of curiosity around blood thinners today.
So
how do I know whether I shouldn't be on them?
Yeah, it's a great question. So if you have atrial fibrillation and you've calculated your CHADS VAS score, which remember, all you really need is a computer and electricity. And if you got those, you're all set. Figure out your CHADS VAS score. If it is 2 or higher, the benefit is there to be on a blood thinner, period. You really should consider being on a blood thinner. If it's below that, 1 or less, you really don't need a blood thinner and you wouldn't benefit from WATCHMAN. But the patients we see who we want to get off of blood thinners are having problems tolerating the medication. The most common is falls. As we get older, our risk of stroke goes up, our benefit from a blood thinner goes up, but our risk of bleeding and complications from falls goes up as well. So that's one reason. Another reason is some people are on medications that interact with these drugs, and they really shouldn't be on both of them. So they need a drug, for instance, for rheumatoid arthritis, for instance, or chronic back pain, but they can't take that and a blood thinner. So usually your doctor, your family doctor or a cardiologist, whoever you're working with, will be able to identify those reasons why. That is why you should not be on a blood thinner. Now, we have had patients come to us who are professional motorcycle rider, for instance, or a fellow who climbed electric power poles. Those people really probably shouldn't be taking blood thinners, so that was an indication to stop as well. Most people, as they're getting older, have had some issues with gastrointestinal bleeding or nosebleeds or falls. Again, those are the more common reasons.
Okay, and we're going to end on a yes or no. Does WATCHMAN also reduce the risk of stroke by 2/3 or more? Yes or no?
The answer is yes from a blood clot, and it's more because of the bleeding caused by bleeding into the brain from being on a blood thinner. It reduces that completely. So at least as much or more, it reduces it, yes.
Fantastic. Thank you so much, Dr. Reiss. Well, that will conclude our question and answer session to keep us all on time today. Hopefully this presentation provided some great insights for you personally or to share with friends and family who have heart disease concerns. Managing heart disease, as many or some of you may know on the line, is often a long-term journey filled with important decisions along the way. We encourage you to bookmark our microsite shown here on the screen to learn even more about WATCHMAN and PeaceHealth Heart Services, or to request a consult with our cardiology team. In addition to the appointment scheduling form you'll find there, you'll also see helpful patient education resources like our heart risk assessment tool for those of you who haven't been diagnosed with heart disease but are kind of curious, downloadable guides explaining the WATCHMAN procedure that was discussed today, and insights about why to consider PeaceHealth for your heart care. And finally, as mentioned at the beginning, we value your feedback on today's session, and I do want to apologize for some of the audio kind of video technical difficulties, but I think we kind of persevered through them as best as possible. We do invite you to complete our brief survey that will be sent to you following this webinar. And yes, we and I do read all comments that you send in, and those will give us a great idea of how to improve in the future. And I'll look forward to seeing what other heart or other health topics you would like to learn about in our webinar series. So you'll have an opportunity to let us know when you fill in the survey. So again, my name is Chris Caldwell. It has been my pleasure to be with all of you today. This concludes our webinar, and I wish all of you the gift of heart health and wellness this holiday season. Thank you again so much for being here.